Good afternoon, everybody. Welcome back from lunch. Tēnā koutou. My name's Alison Eddy. I'm a member of the PMRC, and I started my tenure there as a member of the Maternal Mortality Review Group. And in that role, we do a lot of in-depth specific case reviews of maternal mortality, and it became apparent very quickly that suicide was a leading cause of maternal death, and unfortunately that hasn't changed in the 10 years since the committee has been collecting and examining the data. So the purpose of this session is to look at maternal mortality related to suicide, and we have a range of speakers offering a range of perspectives on that, so hopefully they can shine a light on the information, and hopefully you can take away some practical thoughts and useful information that may help you in your work. So I'd like to introduce our first speaker. Liz McDonald is a perinatal psychiatrist and the clinical head of the Christchurch Mothers and Babies Service, and she's also on the Maternal Mortality Working Group.
Thank you. Now, as we've heard, suicide remains the leading single cause of maternal death. And just a reminder, but our maternal suicide rate is 7 times higher than that in the UK, so we have a real problem here in New Zealand. As we heard earlier, 57% of those deaths are Maori women, and from last year's report, Maori women tend to be much younger. They're more likely to die early in pregnancy or post-termination of pregnancy, post-TOP than their Pākehā counterparts, and have multiple risk factors. But what I'm going to talk a bit more today about is our practice points. Now, I don't think anyone in this room will believe that pregnancy and postpartum is protective, I hope. But just in case anyone does, it's really not true. Depression and anxiety are extremely common in pregnancy and postpartum, and is often underreported by women, and has major potential negative effects on the baby. Childbirth is a major trigger for relapse of bipolar illness and postpartum psychosis. And women with trauma, personality disorder, substance abuse are also at very high risk of difficulties in relapse, and I think are quite a neglected group. Now, I'm going to talk a little bit about some women's stories. We can't talk about the women in our report. These are stories from women that have died overseas. And I apologise if this is quite harrowing for us to hear, but I think it's very important for us to hear so we understand how important this is. This is Daksha Empson and her baby Freya. Daksha took her own life and that of her babies a few weeks after she delivered. She was psychotic at the time. Now, Daksha had bipolar 1 disorder, so she had a very predictable risk of becoming unwell, a 1 in 2 chance of becoming unwell, but the system failed her, and it was a very avoidable death for her and her baby. What the practice point says is that it's very important to identify women with severe mental illness, that their medications should not be stopped without consultation with a doctor, that women with severe illness should be referred to a secondary mental health service, or even preferably a maternal mental health service during pregnancy, even if they're well. Now, that's a very important point because the risk of becoming unwell is very high. So even if they're well during pregnancy, they need followed up. They should have a perinatal mental health consultation, and they should have a mental health birth plan. And there's an example of that in this year's report, outlining their management around delivery, with close monitoring being part of that. And if Daksha had any of that, then this would have been a very different outcome for her and her baby. Now, the practice point also talks about what are the red flags that we need to get concerned about as clinicians. What should you be thinking, this woman needs to see someone today? What should you be picking up the phone about urgently? And just some examples are suicidal thoughts, thoughts of harm to the baby, any indication the woman's becoming psychotic. This was a woman who, another woman who died by suicide in the UK. She was actually being treated for anxiety by her GP, but she was beginning to behave rather oddly. She began to believe that her neighbours were spying on her, and she was putting a camera out her front door to watch out for people coming in. Very, very out of character behaviour, and it sounded to me as if she was becoming psychotic. So any alarming behaviours like that, it's really important that those women are referred urgently. And finally, this is a woman in the US that died after her relationship with her partner broke up. And I think that this really highlights the importance for us of having a really holistic understanding of what's happening for a woman. Many of the women that died in New Zealand had major relationship stressors at the time of her death, so we really need to understand the stresses that the women are dealing with. And just to finish in a good news story, this was a young mum who all the red flags happened for. She became psychotic in the postpartum. She had voices telling her that she was a bad mother. She felt profoundly disconnected from her baby. She even had thoughts of wanting to drown her baby. But for her, the systems kicked in well. She was identified. She was referred for treatment and she had a very, very good outcome. And she was so pleased by this that she actually went to the newspapers a year or two later to see how well it had worked out for her. So this is an example of when it all works well. So just to finish off, I'd just like to say it is possible to reduce suicide rates. Other countries have shown us that this is possible. I think part of that is ensuring that women have continuity and equity of access to good maternal and infant mental health care in New Zealand, no matter where you live, no matter what your ethnicity is. And to that end, we have recommended that there should be a perinatal and infant mental health network set up. That's a work in progress at the moment, but I really feel hopeful that this will be up and running and will have good benefits for services. And just a personal interest of mine, but I think for people working in maternity, early identification of impaired bonding, parenting difficulties, I think that's great if we can identify that and get in early. And I think that's a really important way of breaking cycles of intergenerational trauma and abuse. And I think that gives a good insurance for our children of the future. So thank you.
We'll have an opportunity for questions for all the speakers at the end of the session. But now I'd like to introduce Dr. Rhys Tapsell. He's a psychiatrist working in Waikato, where he's currently Director of Clinical Services for Mental Health. Thank you, Rhys.
Kia ora tātou. Katoa kēnei te mihi kia koutou. Ka tautohunga mihi kua mihi kia rātou ko he te pō. Kia rātou ngā pākeke, ngā matua, ngā tamariki, ngā mokopono hoki, haere atu rā koutou ki te kāinga tūturu. Piti tātai hono, rātou tuke mati kia rātou, piti tātai hono, tātou ta honga ora kia tātou. Hello everybody. As was said, my name is Rhys Tapsell, and as a Maori psychiatrist with really minimal involvement in perinatal mental health, I wanted to just perhaps talk a little bit about what I think are some of the really important background things that perhaps those of you working in the perinatal sector may wish to reflect on in terms of your practice. Can I also, first of all, just point out that I had the absolute joy on arriving here of having a cup of coffee with one of you who delivered my now 25-year-old boy. Is this page up, down? Green arrow. That one.
Yes, so let's go forward.
Sorry, I thought I pushed that.
Okay, oh, I see what's happened. Sorry. For some reason it's come up with this here. Okay, that should be good to go.
Cool. So what I thought I'd talk to you about is talk a little bit about Maori mental health as we know it, from a range of different studies that I've been involved in that others have reported. So first of all, and this is reflecting really on the Te Rau Hinengaro, the New Zealand Mental Health Survey, which adopted a methodology that looked at Maori in a way that made some of the findings particularly valid. We suffer significant burden of mental illness, and this is a community-based study that was conducted right across the country, of major depressive disorder, anxiety disorders, bipolar mood disorder, and in particular alcohol and drug disorders. And I want you just to remember that alcohol and drug disorders were the one group of disorders, or the one particular group of disorders, for the purposes of today's talk that I think is significant. And of all of those disorders, 75% of them were moderate to severe with multiple comorbidities. That's comorbidities with physical illness as well as with other mental illness. And yet despite that, service access was very poor, with significant numbers, the vast majority of people actually having no access to specialist services. What we know about self-harm from that study is that it's common. And most of you will know that self-harm, previous self-harm, is one of the significant risk factors for completed suicide. Among a community sample, it was common, with something like 27% of people actually passively thinking about suicide, 11% actually having plans, and 11% actually having made a previous attempt across the lifetime. And this was highest, as I say, in females, in what I would consider, certainly in the first group, as childbearing age. And as I said, service access was poor. If we look at some of the low prevalence disorders, so some of you will know that the disorders that I talked about earlier are disorders with a high prevalence. They're quite common. If we look, though, at the low prevalence disorders, and we're including here the psychotic disorders and the like, the relative risk of being Maori and admitted into an inpatient service with a diagnosis of a major depressive disorder or of schizophrenia has a relative risk of about 2.5 times. You are 2.5 times, if you are Maori, more likely to be admitted into an inpatient unit, and a relative risk of 2.2 of being admitted into a community mental health service with schizophrenia, but interestingly not with a major depressive disorder. And what that might reflect, we think, is the fact that the big difference between access to services, access to specialist services between Māori and non-Māori, is that we Māori tend to experience that by coercion, through the police, through the correctional system, rather than being referred by our general practitioners. And that may reflect that difference, particularly in terms of major depressive disorder. And we Māori have 3 to 4 times the age-adjusted rate of being subject to a compulsory treatment order, which, when you think about it, might in fact make some sense if in fact we have a relative risk of 2.5 times having a severe disorder that might require that as part of treatment. And as I said to you before, increased access to being subject to the Mental Health Act, subject to compulsion, and we have very different experiences of care, much more likely to be subject to or to receive seclusion, much more likely both to be the victim and the perpetrator of violence committed in an inpatient unit. What about suicide? What do we know about suicide generally? Over time, the rates of suicide were actually reducing through until about 2013, where there appeared to be a spike and then some suggestion that we are again increasing in our rates of suicide. And you will, all of you I'm sure, know that we have one of the worst suicide rates in the Western world. And the age-adjusted rate of about 136 per 100,000 people. Another interesting point, only 46% of those people with completed suicide actually are within any sort of formal specialist service. The more important point there, I think, is that 54% are not. So 54% of people who commit suicide have not ever had any access with specialist mental health services. And the rates for young Māori are high and seemingly getting higher. I don't propose to go back over the risk factors for suicide, but I think they are important for those of you working in the perinatal field, because I think that oftentimes, if we consider the point that I made and points that have been made earlier about access to specialist services, you may in fact be the only ones that have any kind of opportunity to make an assessment of whether someone is in fact, whether a pregnant woman is in fact at risk of hurting or killing herself. And then what would I suggest are some of the learnings? So if we pull all of that together, and I consider that in the context of a young Māori woman about to give birth, as I said to you earlier, I think that it is really, really important for many of you to remember that you'll be the first and sometimes the only person to see some of these young women. And so it is the opportunity for you to make a full assessment of that woman and a full assessment of all of the risk factors that woman in her social context might present. I think that it is an opportunity to identify some of those risk factors and to refer as possible and as necessary at that time. And I think it's important to address all of those risk factors, and I think, you know, I've showed you some of them and you've heard about quite a few of them over the space of the day. Can I just say one thing about cultural assessment, and that is this, that I think cultural assessment, particularly in young women and in young Māori women, it's important not to make the assumption that the predominant culture for that young Māori woman is in fact her Māoritanga, and may not necessarily be. And again, really just underlining some of the points that were made earlier about individualising that assessment and getting a clear idea for yourself about where she might, what is the predominant culture for her, and where might her most significant supports lie? Where might your allies, in terms of encouraging her, supporting her, assisting her to get care, where might they be? Also, of course, the importance of having a skilled and competent workforce. And when I say competent not only in terms of clinical skills, but competent also in terms of knowing, understanding, and being able to access those very cultures that I talked to you about, and remembering that some of those are quite tricky. Some of those might be quite tricky cultures. And then knowing how to access appropriate community and specialist supports. And I say community supports because, of course, again, for many women, it is the community supports that are likely to make the difference. Many, of course, will require specialist referral and specialist care and treatment, but for many, the most significant difference will be made by their communities, by their families, by the people who are close to them and who care for them. Thank you.
Thank you, Reese. I think a lot of those points were highly relevant from the work that the Maternal Mortality Review Group's done, looking at cases. I think there's a lot of synergy there. So I'd now like to introduce Victoria Parson, who's from Postnatal Depression Wellington. Victoria is the Executive Director of the Postnatal and Antenatal Distress Support Group, and she also works with pregnant and postnatal women throughout the Wellington region. Thank you, Victoria.
Hello, everybody. I had an awesome time researching for this. I've gotten a lot of voices sort of from our community around what worked and what didn't in terms of their midwifery care, and everybody loves midwives, basically, so thank you for the work that you do. I had a lot of filtering, and today I'm going to sort of talk a little bit around P&D Wellington, who we are, share a personal perspective on the things that my midwife did that was great, and yeah, share the voices from our community. So we support parents in Wellington by providing phone referral and support. Email, you can email us. Anybody can refer to our agency. We deal with sort of mild to moderate symptoms of post and antenatal distress. We have casual listening groups, a closed moderated online support group, and this was where I asked the question and received the consumer responses. We offer a low-cost counselling service, and we do a Purple Book resource, like an educational resource. So we operate Wellington-wide. Fees are from $3 free to $65, and all of our counsellors are parents, receive supervision through us, and are in training or fully trained. So I'm just going to speak a little bit to my personal story. As a midwife, you're with women in the present, but you're also accessing the past and the future when you are with them, you know, with women, midwife. So what really was amazing about my midwife, she was with me for both of my pregnancies, and I'm going to speak to the second one because she knew in the present of my second pregnancy what my past held, which was a history of trauma, an abusive relationship, abortion, financial trouble, birth trauma. And so she employed the art of storytelling. She made me tell my story over and over and over again. And then when things started to go wrong early in my pregnancy, we'd opened the door of the storytelling. I felt so safe with her. She'd sit there knitting, and ask me questions, and I'd tell her my story. So when I started to develop obsessions and fixations, when I started to go down internet rabbit holes about child abuse cases, she was sort of like, oh, this is not, normal. And so she adopted a multi-agency approach, so she referred me to maternal mental health straight away during my pregnancy. And it was incredible because I got some incredible support from them that enabled my work with my midwife to be about the birth. She gave me some beautiful resources to sort of counteract what was going on within my PTSD and my OCD and my anxiety, and really gave a positive focus to the journey of my birth, while in the background I was doing this other work with maternal mental health. So everything, no matter how bizarre, she just acknowledged and affirmed what was going on, and in that way she really safeguarded the future of my family and of my second baby. And sometimes it wasn't really what she said, it was what she didn't say, because she knew I was really anxious. So my second son was born 3 weeks early, and I was on an absolute knife edge, and he was needing to be monitored. He had quite heavy jaundice, and he was pretty underweight and losing weight. And so that could have become a complete obsession for me at that time, and a complete source of anxiety, and she just navigated it so well. We knew about it, we knew that it was going on, but it wasn't a focus, and so I was able to relax, and I was able to feed my baby, and things like that. So she was just incredible, and it was really her use of language, the storytelling, the positive reinforcement, holding space, that created the best outcome for us. So this is from our group. The point I'm trying to make is words matter. Even what they may consider insignificant remarks can have a huge effect, either negative or positive, during such a sensitive, transformative period of life. So a quick note on language. When I collated all of the responses from what worked and what didn't for your mental health during midwifery care, the things that hadn't worked were experiences where midwives minimised the experience of the women, were judgmental, or were threatened, for example, by a lactation consultant, or were threatened by the mum pulling in other kinds of support. What did work was holding space, that's really being with someone, was positive reinforcement, acceptance and permission, really listening and providing information, thinking about what comes next, accessing and referring to the right supports, and again, the storytelling, gaining knowledge, and also helping to process a birth story afterwards. With anxiety, I found it enormously helpful having someone who was able to stay really calm and basically reassure me everything would be okay, but without minimising what I was feeling. My midwife was also a great advocate and got me referred to maternal mental health really quickly. There are a few other examples of other people who maintain the same really calm, empathetic manner, the Karitani nurse, psychiatric registrar, and they all really stand out in my mind as people who helped me recover, because you can internalise that voice when things are bad. Anyone who acted like I needed to try and get the situation under control myself would send me over the edge. Anxiety is perverse like that. Also, my midwife could read me really well. I think that probably comes with experience. I had the same midwife for both babies. She is awesome. We really connected and still stay in touch. She bought me coffee on days she knew I was alone after number one, and she kept my toddler entertained and engaged. She was always at the end of a text or Facebook message. She fully supported me when I didn't want to be induced the second time, and fought in my corner and cried with me when the hospital ob said we had to, then cried again when the hospital changed their mind and let me do it my way. I also spent time in hospital pre and post both babies, had some awesome midwives in there. The yanking boobs thing, that did come up quite a lot. I feel like there was a lot of concern around body autonomy, and I can understand how it gets to the yanking boobs point. But that was a feedback. So I feel like a good connection is so important, but also really hard when you only have limited appointments and time together. I struggled with having a collective of midwives. The one that was at my mildly traumatic birth during the Kaikoura earthquake isn't the one who did home visits, so I didn't get a chance to talk through any struggles of those first hours and days related to how the birth went. So that kind of sounds like a bit of a lack of storytelling to me. My midwife contributed to my P&D, I think. She was incredibly judgmental about the fact I went to a private lactation consultant rather than talking to her about feeding issues and Bub's tongue and lip tie. She made me question my decisions when I was already in a really vulnerable place. So that's kind of that being threatened situation. My midwife watched me spiral into P&D and kept saying she wasn't sure what help to provide. She was inexperienced and didn't have enough understanding as to what organisations are out there. She seemed to miss major red flags in the lead up to me becoming very depressed. It was only at my 6-week appointment when she checked me out of her care that she referred me to my GP and asked Plunkett to do a home visit another week, and I very much doubt I would still be here. So I guess that early noticing is good too. Our midwife was awesome. She was very kind and empathetic, but practical and empowering. Her response, even when things were tough, was, "Okay, what can I do to help you?" She respected us and gave us time to think about our answers, ask questions, and learn about different options. She took it seriously when I wanted to plan ahead, to have supports in place, and never pressured me to deploy them or not deploy them. She helped make space for us to give birth the way we wanted to when our son died in utero at 32 weeks, which helped us get family here from overseas, prevented me needing a C-section, and was an amazing reassurance and support. So I'm conscious of time because we've got a lot to run through. But there's some other pretty beautiful quotes. I like the bottom one because it's really about holding space. It's just about somebody who's really at rock bottom and just needs their hand held and to be made a Milo. And you guys are amazing at that. So thank you, and that's us there.
Thank you, Victoria, for sharing your story so candidly. And I think what you've illustrated is that the intrinsic value of the relationship that we as midwives believe is important to women, and I think is sometimes hard for the rest of the health sector to understand. It's not just having a cup of tea, it's actually creating a space for women to be able to feel safe. So thank you. I'd like now to introduce Tracy. Tracy's a social worker and is currently the team leader of the Specialist Maternal Mental Health Service at CCDHB, where she's worked for 18 years. And she is going to talk about the service that they have developed for women in their region.
Kia ora tātou. Right, let's see if I can do this. While this presentation, or the collective bits of it, are actually about maternal mortality and specifically maternal suicide, my focus is about an initiative actually that our team has been involved with developing. It's an evolving process really around maternal wellbeing clinics, which we have been offering in our area, which is Kaplan Coast District Health Board. That's Wellington, and that's Wellington up the Kapiti Coast, Wellington City and up the Kapiti Coast, and also Hutt DHB, because we are a regional specialist mental health service, and we are part of adult mental health services. So right. Is it the little one?
That one, yeah. Just press that nice firmly.
Oh, okay, cool. So this is our team. So we are part of adult mental health services. We are community-based, and that's really important for us. And we're what's called a tertiary mental health service, in that we receive referrals from other health professionals. We work with women who are pregnant and postnatal, and there's a bit of confusion. We do have a referral criteria that is up to 12 months of age, but then we work beyond that, and quite some time beyond that at times. We're a multidisciplinary team, so we have a number of different professional groups, and from psychiatrists, psychologists, and occupational therapists sometimes, nurses and social workers. And we have a very strong focus on relationships. That's the importance of the mother-infant relationship, as well as our relationship with the woman and families that they come from. So we have a variety of ways that we work, including the care management, individual therapeutic work with people and groups, and of course medications in that mix at times, not all of the time. And we offer quite a lot of consultation liaison to other teams and other services, so teams that would refer to us, or we also have some exclusions in our service as well for who we don't work with. We do not take on all the pregnant women in this area. So when they already have an adult mental health service, we do not take them on. They remain with their team, but we're happy to work alongside the team that already has involvement with them. So this was a bit of an initiative, really, to actually do something a little bit different and look at the ways that we could strengthen our relationships with other health professionals working in the maternity space. And it really came out of, we're forever trying to be working on relationships with the other health professionals and wanting to give the best opportunities across care teams to work with the women and families that we're working with. And so over time we've gone out to all sorts of places to try and help people understand how to access our services and what our role is. And in that, my colleague and registered nurse in our team, community mental health worker Cindy Crowley, some 4 or 5 years ago in the hut where she was primarily working, eventually this evolved into a liaison with Judy Ormond, who's an obstetrician, gynaecologist who was working out there at the time, and they together started to work on having clinics for the woman coming into clinics to have a mental health focus as well, so like an obstetric wellbeing clinic. And the aims were really around wanting to develop those positive relationships and wanting to strengthen and develop capacity in the midwives, the LMCs, the primary midwifery services, the obstetricians, the doctors working there, and also to support those people, because sometimes I think it would seem that they are pretty isolated and on their own and can get really concerned and are not sure about how to access mental health services, or, I mean, we struggle with it ourselves, but it is a difficult service at times to access. And people are often unclear about whether this is a person that will require a mental health service. So basically we offered the opportunity so it works differently across the 2 DHBs. We have clinics at the Hut and we have clinic at Wellington, and they're staffed by different clinicians, and they are a bit different actually in what they're offering. But essentially they are booked outpatient slots for face-to-face contacts with clients that are referred by LMCs or DHB primary care midwifery or obstetricians. There are definitely some exclusions. If you're already under a mental health team or waiting to be picked up, then it's not a backdoor access to that service, our service. And there are also other colleagues that it's really important, the social work colleagues that work in services. That is always really important. So even if they're not part of mental health and they're not part of midwifery, there are also other services that can sometimes be importantly needing to be linked in as well, and we don't want to take the place of those. So we have a number of outcomes from the consults that we have. We have women that come in and we see that they're not at a level where they require ongoing contact from a mental health service, or something's resolved for them in the period that they have spoken with their midwife and gotten upset. There's always opportunity for a useful discussion that's really fruitful, and even at times there'll be a really good conversation about what are your usual coping mechanisms, what are the things you've done before that have been useful for you, do you use meditation, do you use relaxation, do you have apps that have been useful for you, what are your early warning signs, just giving people some prompts about what they've used in the past that's been useful. Another outcome is that they will come back and see us. That would possibly be around being unsure whether they are going their issue or where things are up to them is going to resolve or not. I actually prefer not to have this option, because if I've suggested some other linking into another service, then I don't want them to wait and not do much and come back for an appointment in 4 weeks or something like that. I really prefer that they use other good services, and we do a lot of linking in. Just big heads up for P&D. We do a lot of referring to P&D, and they offer a wonderful service. So we would suggest a lot of women giving themselves that opportunity to go and take some space for themselves and work through some of the things that are happening for them. Sometimes there's a lot of information that we have. People might need information about WINS or refuge or Shakti services. They might be looking for information around paternity or custody and access issues or immigration or other family support services, anything that's going to be useful for them. But being able to have that opportunity to focus on what is important for them is really what it's about, and having that opportunity to listen. And I think that message has come up today. I heard that in the speaker before lunch. And one of the really important things is, and then there's the recommendation back to the referrer about a maternal mental health referral, because that is also one of the things that we're doing, really. We're screening for where women are up to, and so that is very much in the mix as well. And one of the things that I always underline with women is that it's really important that, you know, the social isolation and the staying not well, not happy, and not seeking support, that's, you know, they've already reached out and actually made a link through their midwife or whoever it is and with us. And, you know, we do in our work with maternal mental health have that situation where people have sat on being very unwell and nobody has helped them access services for a long time. So we are getting in early there, and that is what's really important. And what I was going to say, the importance of the feedback loop. So one of the really important tasks is that we get back to the referrer to provide a snapshot of the outcome and following the assessment, and this is always welcomed and helps in, you know, the development of the positive relationships together and developing the midwifery capacity and doctors to work better with emotional and mental distress that women are experiencing. I often hear women say, like Vic said before, they really like and trust their midwife, but she's often too busy to hear their concerns and can become worried when she's really emotional or upset. Thank you. Is that 3 minutes? So just going... So these are quite a new initiative in that, well, not new actually, but we haven't actually had the resources to do any stats or data or anything like that. In fact, we don't have the resources to do the clinics, in honesty, but we've decided that it is a really important thing that we can offer. I'll just go through quickly. We have got a couple of other things that we do use. You won't be able to read this very well, but I attached it to the back of the presentation because I think it could be useful for people. So that's something that we developed in our service, and it just gives a bit of a guideline or a model for other services about where to go for help if you've got mental health concerns and whether it's a mental health concern. The other couple are around 2 resources that we actually have. And one is an e-learning toolkit, which was developed by Mark Hathaway and our team with the project manager, which is aimed at support workers upskilling for working in this area, and I think it's got quite a broad application for this client group, for other people working with women who don't have a mental health background, and it's a really useful 7-module kit that people can access via the Ministry of Health website. And the other one is an educational video which was developed for primary care professionals, and is, again, women speaking about their own experiences and what they wanted and needed from health professionals. So anyone can tap into those if you want to. Thank you.
Thanks, Tracy. So we've got a few minutes for questions before the next session starts. 5 minutes, according to Jess. Any questions? There's a couple of mics there. Anyone? No one's standing up. How long did it take you to set up the service, Tracy? That's the question here.
Oh, the maternal mental health
Yeah.
service.
You've got a mic on your table there if you want to talk into that. Yeah.
Is it on? Can you hear me? Yeah. Look, it's been in operation about 20 years now, and it was established with the Mason inquiry money. And so it started very small, and it has evolved a very little bit. I mean, up until about 2.5 years ago, where there was a little bit more money that was given out, it's remained the same. And the numbers of women accessing the services these days is very different from what it was when it started. So it's a DHB service. So yeah.
Any other questions? There's someone over here. Oh, sorry, just here.
Tracy, do you have anything to do with the mothers or parents and the NICU?
We have, that's a bit of an ongoing conversation. We have offered support opportunity, a group in the past for that group of women, and it is being revisited at the moment. There is social work at the Wellington NICU. But in our experience, the women who are in the NICU with their baby are under an awful lot of pressure, and they are not really able to fit into a scheduled group, or don't want it, I think, at the time that it's on offer. I think, and for other separate services to come in and offer that, I think that it's probably best offered ad hoc by staff along the way, or post returning home. That's been our...
It seems to be, can you hear me?
Yes.
It seems to be sadly lacking in the neonatal unit. My view on it is it should be looked at, I think, more thoroughly, because I think these mothers really miss out on
I guess
getting
one
that
of the
support.
things that's tricky is that I would say it's not necessarily a mental health issue. I think it's more about how they're presenting at that time would be how anybody would present. It's a very stressful and difficult life episode experience. So whether that's mental health,
I guess it's not a mental health disability, or it's not, it might not be postnatal depression, or it's not bipolar, but it's definitely mental health that's affected.
It is an ongoing conversation, and I am aware that there will be another round of possible services offered in the next while. Yeah. Thank you.
One more. Probably got time for one more question. Any final questions from the floor? No? Well, thank you. Please join me in thanking the speakers for their excellent presentations.